Go on to our next topic is oral vancomycin or intravitreal ganciclovir in the management of CMV retinitis. And we have Dr. Megha Gulati, who's a consultant vitreal retina services and Uvea and immunology from Visakhapatnam. And countering her is Dr. Mallika Goel, who's a senior consultant, heads the retina, vitreous and uveitis services at Apollo Eye Hospital, Hyderabad. So let's hear this interesting debate.
Thank you, Dr. Chitra. Am I audible? Good evening to all. Am I audible now?
Yes, yes, Dr. Megha, go ahead.
Is my screen visible in the slideshow?
Yeah.
Thank you. So, starting with the topic CMV retinitis. So, this disease, it is characterized by progressive necrotizing retinitis, which can lead to blindness in patients who have immunocompromised status. And it can be seen as an AIDS-related CMV retinitis or non-AIDS-related, especially in patients who are on pharmacological immunosuppression. Now, in 1980s, before the starting of heart therapy, the FDA-approved drug was intravenous ganciclovir in the induction course of CMV retinitis. And for the maintenance, we had oral ganciclovir. Now, the problems which were there was the need for catheterization for intravenous ganciclovir and very poor bioavailability of oral ganciclovir, and it has a side effect which is myelosuppression. So to overcome this catheterization issue and the oral bioavailability, the Val ester of ganciclovir was introduced, and to overcome this myelosuppression, the first case in which the intravitreal ganciclovir was used was a patient who was having a pre-existing myelosuppression and developed CMV retinitis. So now let's come to our topic, oral val ganciclovir or its intravitreal ganciclovir, which is better. Now, before I start with my topic, I would like just to start with a simple example, and I would like to give the scenario to you. Patient presented to the clinic with this clinical picture of diabetic retinopathy, PDR status. Now, this patient, what treatment will you advise? Whether it will be just an intravitreal anti-VEGF injection, or would you also counsel the patient to control diabetes mellitus and visit his diabetologist? Because the patient is also at risk of involvement of multi-organs because of the diabetes mellitus. In same analogy, CMV retinitis, what should be the management? It should be only intravitreal ganciclovir or also systemic anti-CMV therapy, because whether the patient is HIV or non-HIV, it has a risk of extraocular CMV involvement. So let's start. This question does not hold valid. This option of or should not be there, but let's see which is better. Now, I will answer this question with the help of 4 questions. How effective is oral val ganciclovir over systemic ganciclovir? CMV retinitis, is it just a unilateral or a bilateral presentation? Does CMV has only ocular involvement? And what are the indications of intravitreal ganciclovir or specifically the combined therapy? Let's start with the first question. How effective is oral val ganciclovir over systemic ganciclovir? Now, you can see this area under plasma concentration in time curve. It is comparable between oral val ganciclovir and intravenous ganciclovir. So studies have proved the bioequivalence, efficacy, and safety of oral val ganciclovir over intravenous ganciclovir as well as oral ganciclovir. Coming to the second question, CMV retinitis, is it a unilateral or a bilateral presentation? Now, in almost 2/3 of the patients who present with CMV retinitis, it's the unilateral presentation, but it can become bilateral if not treated appropriately, because CMV retinitis occurs via the hematogenous dissemination to the eye. Now, in patients who were only treated with intraocular treatment, studies have reported that there was an increase of almost 22 to 35% in the incidence of new CMV retinitis and the untreated contralateral eye. And what was the primary risk factor? So the risk factors which were associated with high involvement of the contralateral eye was the low CD4 count and a high CMV load. So to treat the low CD4 count and the high CMV load, there is a role of systemic anti-CMV therapy and heart initiation, especially with the immune reconstitution. So the bilateral involvement or the contralateral eye involvement the incidence can be reduced by starting proper systemic anti-CMV therapy and the antiretroviral therapy. Coming to the third question, does CMV has only ocular involvement? So retinitis, it is the most common clinical manifestation of CMV, but it's a multi-organ involvement. And to give few examples, it can present as encephalitis ventriculitis, pneumonia in form of lung involvement, adrenalitis, and gastrointestinal involvement in form of esophagitis and colitis. So studies have shown that the patients who were treated with only the sustained release implant, the biopsy of such patients has shown that 31% of these patients had evidence of systemic CMV disease, which was left untreated. So having answered the three important questions, how is oral valganciclovir important? Is it only unilateral or bilateral presentation, or is it only ocular or also extraocular involvement? Let's see the indications of intravitreal ganciclovir or combined therapy. Now, no drug is free of side effects, so ganciclovir has myelosuppression, but neutropenia was seen in only 11 to 13% of the patients. So indications of combined or only intravitreal therapy can be zone 1 CMV retinitis. When there is pre-existing myelosuppression or renal failure, such patient needs dose adjustment. So low dose valganciclovir can be given with intravitreal therapy. And in patients who are pregnant or due to socioeconomic consideration when the patient can't afford the systemic treatment. So what did we learn by answering these 4 questions? So I would like to conclude that oral valganciclovir for CMV retinitis mainly reduces the mortality, visceral CMV disease, and dissemination to the second eye. In addition, reduces the pill burden and the intravenous catheterization. I would like to conclude with the statement that CMV retinitis is just an ocular manifestation of a systemic disease. Here we have the opportunity to treat this opportunistic infection, and let's not miss it. Thank you.
Thank you very much. I have a simple question and Srinivas can take the rest. For CMV retinitis, how long should we continue the medication?
So CMV retinitis, as I told you, the primary risk factor is the CD4 count. So it has an induction and a maintenance dose. The induction, for the induction, we are giving oral valganciclovir in a dose of 900 mg BD for 3 weeks. And the maintenance dose, it depends upon how the CD4 count improves with initiation of heart and valganciclovir. So if the CD4 count improves to more than 100, then it has to be continued for 6 months in a dose of 900 mg OD. But if the immune reconstitution is better and the CD4 count is improving to more than 200 after initiating heart, then we can continue the maintenance therapy in form of 900 mg OD for 3 months.